A very good afternoon to everyone. I, Shreya Srivastava, on behalf of Quality and Patient Safety Division, National Health Systems Resource Center, New Delhi, extend a warm welcome to Dr. J.N. Srivastava, sir, Advisor, Quality and Patient Safety Division, NHSRC, Dr. Sangeeta Sharma, ma'am, President, Delhi Society for Promotion of Rational Use of Drugs, and to all the participants. I also welcome our guest speakers, Dr. Nilima Gupta, Director, Professor, and Head, Department of ENT, UCMS, New Delhi, and Dr. J.C. Pasi, Dean, Principal, and Professor, ENT Department, World College of Medical Sciences in Haryana. Now, I would request Dr. Jain Srivastava, sir, Advisor QPS, to please address this gathering. Over to you, sir.
Thank you, Shreya. And at the outset, I'm deeply honored and humbled by presence of such an eminent uh, speakers today, Professor J.C. Pase, who does not need much introduction in the fraternity of ENT, and Dr. Professor Nilima Gupta is Director, Professor, Department of ENT, UCMS. And of course, our flag bearer, one-man army, Dr. Sangeeta Sharma, who has been the force behind this. So, sir, to give you a background that what is this initiative all about and how it was started. But before I come to that, I also want to welcome about 170, 180 odd participants who have connected from all over the country. Those are the logins which in fact we have. And we need to appreciate that at many places, particularly in the district hospitals, lower down facilities, there are people who are in fact normally working day for them also. So in one login, normally there are 3, 4, 5 already over here. I can see that in my room itself, there are, other than me, there are 6 people who are present. So the background goes like this, that about 3 years back, NHSRC, which largely works with for the strengthening of the public health system in the country, all the government institutions largely, and Delhi Society for Promotion of Rational Use of Drugs, headed by Professor Sangeeta Sharma. We thought that let's try to do something to improve upon the clinical practices. And because our focus area is that improving the quality and delivery of the patient safe care, and the quality cannot be only limited to having a better ambience. Of course, those are important, that good behavior and patients being seen, availability of all the drugs, diagnostics. But the clinical, if we are serious about improving the quality, then our clinical practices must improve. And we also appreciated that in many of the places, particularly at the district hospital level, there is only one specialist, maximum in certain specialties, there are 2 of them. And further at peripheral, often it is one all alone. And person has been stagnating over a period of time. All of us come from the same background. But that kind of enabling environment, enabling opportunities for the learnings have not been there. And with the government's focus coming up, that now the care has to be decentralized. And both these institutions, they came together as a capacity building efforts. And it gives immense pleasure in sharing with you that till date, about 12,000 odd participants have attended. And out of that, around 3,400 plus people have been also issued the certificate. It means that they attended all the sessions, including pre-training and the post-training evaluation. Largely, so these are the participants who are there at the PHCs, community health centers, district hospitals, where there are the resource constraint also. And couple of the participants may be from the sub-center level, where we have got the community health officers who are not an MBBS doctor, but largely they are having the BSc nursing qualification and have undergone 6 months supplementary training. So they are also there in providing the care. And the other side is also we are having certain people connected with the specialty institutions. So the spectrum is quite varied. And I'm sure that you will feel that it will be a bit challenging addressing the learning needs of such a vast set of the audiences who are connected with us. And we have been taking up every time a common relevant problem, and that often casually people they talk very loosely, mujhe sinusitis ho gaya hai, but how it needs to be tackled in real sense. And we also realize that antibiotics are being pumped in, and which is often irrational. And the other common problem which is there for today is for epistaxis. And both are these common problems, in fact, which we'll be requesting you that you will speak. In addition, to improve on the clinical practices, also looking at the rampant use of the steroid decongestant, kind of ignorance about the antihistamines which are being used, because in our country we all know that there is no official OTC list, but you can get each and everything when someone goes to the pharmacy, next door pharmacy. So on that topic, Professor Sangeeta Sharma, in every session I admire ma'am for her energy and commitment. That relentlessly, there has not been a single lecture series when she was not around, and she has never not conducted the session. So today she will be talking about just balancing the efficacy and safety in terms of uses of decongestant, antihistamines, and local steroid. I will not go into much detail on the terms of the statistics, because all of you are there and you will be touching upon. And I will just request all the participants, in fact, that please, we will never get such an eminent faculty for this particular relevant problem. So do post your queries. Don't hesitate or don't shy away in asking. And these are the opportunities where we must resolve our queries there. And if if there's a question of common interest, then obviously the faculty would only be talking about addressing one question, and others can take it. It is not that their question or their names are not being read out. So with this introduction, in the interest of time, I will stop over here and request Professor Sangeeta Sharma and other two eminent faculties to start the session. And once again, at NHSRC, we are very grateful. Thank you very much.
Thank you so much, sir, for your kind words. With this, I would like to invite our first guest speaker, Dr. Nilima Gupta ma'am. She has more than 60 publications in national and international index journals and has written over 10 chapters. And Dr. Gupta was a Boycast Fellow in the chemosensory research, and she was also a fellow in allergy, asthma, and immunology. She is also a reviewer of iJohns, and she has reviewed around 100 articles. And she has held positions as executive board member of All India Rhinology Society and is also a president-elect AOI Delhi chapter. Today, she would be taking up the presentation on management of sinusitis. Over to you, ma'am.
Thank you, Dr. Shreya. So we will be talking about sinusitis and its management today. Thank you for the kind introduction. So today we'll be discussing sinusitis and its management briefly. I have kept the presentation quite simple and basic. So I hope everyone will be on the same page while we will be going about discussing sinusitis. So sinusitis is also known as rhinosinusitis because the mucosa of the nose continues into the sinuses. So it is an inflammation of the mucous membranes that line the sinuses, resulting in symptoms such as production of thick nasal mucus, nasal congestion, facial pain, facial pressure, symptoms like loss of smell, and fever, or sometimes the fever may not be there. So this is the definition of sinusitis. We are talking about the paranasal sinuses, which are air-filled cavities in the skull. And I am sure everyone is aware that we have the maxillary sinus, the ethmoid sinus, the frontal sinus, and the sphenoid sinuses. So over here you can see these are the maxillary sinuses, the ethmoid air cells or the ethmoid sinuses, which are multiple in number, the frontal sinus, and the sphenoid sinus at the back. So these are the air-filled cavities in the skull. So the mucosal lining of the sinuses, as I said, is continuous with the nasal mucosa, which may lead to spread of the infection from the nose to the sinuses. And when we are discussing sinusitis, an important area is the osteomeatal complex. So this osteomeatal complex is a narrow common pathway for drainage and ventilation of the frontal sinus, the maxillary sinus, and the anterior ethmoidal air cells. If there is any obstruction of this area, the osteomeatal complex area, so then this is a major factor for development of chronic sinusitis. So if this is the maxillary sinus and these are the ethmoid air cells, this area where the maxillary sinus is draining into the nose, this area is known as the osteomeatal complex. So if there is any obstruction, you can see my cursor. So if there is any obstruction in this area, it leads to development of sinusitis. In chronic sinusitis, the mucosa becomes edematous. There may be formation of polyps, and there is also pathogenesis includes loss of cilia. So there is an impaired mucociliary function. So the normal function where the mucociliary function leads to drainage of the mucus to the posterior part of the nasal cavity, that is impaired. So there is a stasis of secretions. We can classify the sinusitis into acute and a chronic rhinosinusitis. So in case of acute rhinosinusitis, the pathogenesis is infection along with a tissue invasion. And the chronic rhinosinusitis is mainly idiopathic. It results from a dysfunctional interaction at the sinonasal mucosal surface between the host immune system and the resident microbiome. Various theories have been proposed, and these include presence of fungi, presence of resistant bacteria, superantigens, mainly of the Staphylococcus bacteria, so staphylococcal superantigens, existence of biofilms, which keep on releasing the bacteria, and these are resistant to the drugs that we give, the antibiotics. Atopy, so that is allergy. So presence of allergy is also predisposing to the development of sinusitis. Mucociliary dysfunction, this can be due to genetic causes or it can be due to acquired causes. Then various environmental irritants. This environmental irritants, these are increasingly becoming more common etiology for predisposing the patients to development of sinusitis. Then acquired sinonasal obstruction due to various causes and genetic variations of the host. So there are various etiological factors leading to the development of sinusitis. So this diagram illustrates that this is the maxillary sinus, the presence of osteitic bone, presence of staphylococcal enterotoxins, biofilm presence, or presence of eosinophilic mucus. These all lead to the development of sinusitis. Also the concept of the unified airway disease. That is, the upper airways are continuous with the lower airway. So the presence of development of disease such as asthma or aspirin sensitivity, these can also predispose to development of sinusitis in the individuals. So there is basically stasis of secretions, or there is edema of the mucosa which is lining the walls of the paranasal sinuses, and there is an inflammation of the mucous membrane. This leads to symptoms such as increased nasal mucus production, nasal stuffiness or nasal congestion, then facial pain or pressure, fever, and symptoms of headaches and postnasal drip. So they can be classified into major and minor symptoms. Major symptoms, as I said, will include facial pain or pressure, facial congestion or fullness, nasal obstruction, nasal discharge. It may be purulent or non-purulent. Hyposmia, that is a decreased sense of smell, or even anosmia, that is absent sense of smell. On examination, the nasal discharge may be purulent, and fever in cases of acute rhinosinusitis. There's certain minor symptoms such as headache, halitosis, fatigue, dental pain, cough, ear pressure or ear fullness may also be there. So generally it is said that the diagnosis of rhinosinusitis requires two major or one major and two minor symptoms. So any of these symptoms, if they are present, then you can classify the patient into having rhinosinusitis. So as I said, these symptoms along with endoscopic signs of nasal polyps or a mucopurulent discharge coming from the middle meatus and mucosal obstruction primarily in the middle meatus. And if you get a CT scan done, it will show mucosal changes within the osteomeatal complex and the other sinuses. So presence of symptoms along with endoscopic signs and CT changes will indicate that the patient is suffering from rhinosinusitis. So as I said, we can classify it into acute or chronic. So generally the acute rhinosinusitis is of a duration which is less than 3 months, or sometimes we say it as 12 weeks. Chronic is more than 3 months or more than 12 weeks. The patient may be having recurrent acute sinusitis. This is the condition when there are symptom-free periods between the two episodes. So then the patient can have a recurrent acute sinusitis. So acute rhinosinusitis, what is the etiology? Most commonly, there is an acute viral upper respiratory tract infection. This leads to swelling of the mucosa of nose or sinuses, leading to obstruction of the ostia, the openings of the sinuses, leading to reduced clearance of secretions, stasis of mucus, that is accumulation of mucus, and bacterial colonization. The etiology is mostly viral. This will include rhinovirus, influenza virus, adenovirus, the respiratory syncytial virus, and the enterovirus. Only in 0.5 to 2% of cases, there is a bacterial superadded infection, a secondary infection, in which case it will be due to Streptococcus pneumoniae, H. influenza, Moraxella catarrhalis, or also Staphylococcus aureus in 8 to 10% of cases. So what are the clinical features of acute rhinosinusitis? The patient presents with nasal obstruction or congestion, purulent nasal discharge, facial pain, which is mostly unilateral, or facial pain or pressure, fever, and sometimes dental pain. On investigation, the ESR or the CRP may be elevated. How do you diagnose acute sinusitis? It is based on history and clinical examination. And in cases where there are severe symptoms or there is a double sickening, that is the patient is suffering from the disease for about 3 to 4 days and then gets better and then again starts suffering from severe symptoms. So these severe symptoms or double sickening suggests a bacterial etiology. Do we have to go for imaging in all cases of acute sinusitis? Generally, we don't need imaging for all cases of acute sinusitis, only if we are suspecting any complications or if the person is having recurrent attacks of sinusitis, then we should go for imaging. Also, nasal endoscopy, this is commonly, we are doing it, all the ENT specialists, to see what is the condition of the nasal mucosa, whether there is presence of discharge, whether there is presence of edema of the mucus or presence of nasal polyps. In cases where the patients are having persistent symptoms, you may need to go for endoscopic middle meatal cultures if the person is not improving despite antibiotic therapy. So this acute viral sinusitis is often a self-limited disease and the patient gets all right in 7 to 8 days or 10 days sometimes. Symptomatic care is required, like analgesics for the facial pain, pressure, and headache, nasal decongestants only for a short duration. And symptomatic care includes nasal saline irrigation because this loosens the mucus and helps in clearance of the mucus, and steam inhalation. So this would mostly this will lead to subsidence of the viral sinusitis. In cases where there is an acute bacterial sinusitis, you may need to give antibiotics if the symptoms have persisted for more than 10 days, or the symptoms are worsening, or the onset is with severe symptoms. Onset of the disease is with severe symptoms, then you will need to give antibiotics. So the combination of amoxicillin clavulanate is the first line treatment for sinusitis, and in adults it may be required for 5 to 7 days, 7 days or even longer, and 10 to 14 days in children. Complication, the incidence of complication is more in children. If the patient does not respond to this or is sensitive to this, then levofloxacin or a combination of clindamycin plus third generation cephalosporins, cefixime or cefodoxime may be given. If the patient does not improve despite 3 to 5 days of treatment, then the change in medication may be required. If there are allergic symptoms, then antihistamines also may be required, but overuse of nasal decongestants should be avoided. Coming to chronic rhinosinusitis, the duration over here is more than 3 months or more than 12 weeks. And chronic rhinosinusitis is commonly divided into two phenotypes, sinusitis with nasal polyps or sinusitis without nasal polyps. As you can see in these images, this is a sinusitis patient with presence of nasal polyps, and this shows a mucopurulent discharge in the middle meatus. Clinical features again include nasal obstruction, mucopurulent discharge, facial pain, pressure, anosmia, postnasal drip. And on examination, the patient with polyps, there may be a nasal polyp, which is a localized single unilateral enterocornal polyp, or there may be diffuse bilateral ethmoidal polyps. The patient without polyps is characterized by mucopurulent discharge and mucosal thickening due to fibrosis, basement membrane thickening, and goblet cell hyperplasia. So there will be mucosal edema and presence of mucopurulent discharge in a patient of CRS without nasal polyps. Diagnosis we can make with history and nasal endoscopy findings. On endoscopy, you may see nasal polyps or a mucopurulent discharge, edema, mucosal obstruction, and mucosal changes within the osteometal complex or the sinuses. A CT would show a mucosal thickening or opacification of the sinuses and obstruction of osteometal complex. So as you can see over here, these are the CT scans. This CT scan shows the normal. This is a normal CT-PNS, whereas this shows bilateral maxillary sinusitis. You can see that there is a opacification of the maxillary sinus. So this indicates a maxillary sinusitis. In this patient also, there is mucosal thickening on one side and opacification of the maxillary sinus on the other side. So such a CT would indicate that the patient is suffering from CRS. In this CT scan, you can see there is a unilateral opacification and the osteometal complex area is blocked. On endoscopy, you will see presence of a polyp, and this is how a polyp looks like when we remove it using endoscope. So this is a case of enterocornal polyp. So the medical therapy management of CRS includes aims to reduce the inflammation, reduce the bacterial load, and optimize the ciliary function by removing the mucus. So you can start with macrolide antibiotics or non-macrolide antibiotics, and they are given for a longer duration in cases of CRS, chronic rhinosinusitis, unlike the acute rhinosinusitis. Then topical intranasal corticosteroids. These are good drugs in cases of chronic rhinosinusitis because they reduce the polyp size and decrease the rates of recurrence. They are also found to improve the outcomes in patients of sinusitis without nasal polyposis. The steroids that are commonly given are mometasone and fluticasone. and they are found to be very efficacious after sinus surgery. So we tend to give these topical intranasal corticosteroids after the surgery for a longer duration, and they are found to be very effective in reducing the rates of recurrence. I'm sure Dr. Sangeeta will also be talking about the steroids and antibiotics. Sometimes we need to give systemic oral corticosteroids, especially in cases of severe polyposis. So, but it is indicated only for a short-term use, and a prednisolone in doses of 0.5 to 1 milligrams per kg daily for 5 to 10 days may be given. But we have to keep in mind the adverse effects of the oral corticosteroids. Nasal saline irrigation, as I said, improves the mucociliary action. Antihistamines may be added if there are symptoms of allergy. Leukotriene inhibitors, especially in patients with coexisting asthma, montelukast is given in patients with coexisting asthma. As I said, macrolides for a long duration is given in patients of sinusitis without nasal polyps, and short-term treatment of non-macrolide antibiotics may be given in cases of exacerbation with a positive culture. Now, biologicals have also come in, and monoclonal antibodies like omalizumab and mepolizumab can reduce the symptoms significantly, but they are still not very commonly used in India because of the cost factor. When will we go for a surgical management? If the patient gives a history of failed medical therapy, we have given optimal medical therapy and the patient has not responded, or the symptoms are persisting. In patients with nasal polyps, they need to undergo surgery so that the sinuses can be opened up. And because once the sinuses are opened up, then the delivery of the drugs to the sinuses is more efficacious. In patients where there are complications of acute rhinosinusitis, then also we need to go for surgery. The surgery that we do is the functional endoscopic sinus surgery. You all must be aware of this. Now, this is the surgery which is most commonly done for chronic rhinosinusitis. It seeks to remove the polyps, open the ostia of the sinuses, clear the inspissated secretions, and improve the sinus ventilation and sinus drainage. So we use a rigid endoscope, and these surgeries can be done under local anesthesia or more commonly under general anesthesia. The aim is to improve the sinus ventilation and improve the sinus drainage. We do open up the sinus ostia so that the mucus can be cleared and the polyps can be cleared. So just we have talked about it briefly, touching this chart. So if the duration is less than 10 days and it is improving, then it is mostly a viral sinusitis. If the duration is 10 days without improvement, there is a double sickening, symptoms improve and then worsen. Or if there is severe symptoms and fever is there with purulent discharge or facial pain, then it is mostly a bacterial rhinosinusitis. You would need imaging and medical therapy for these. We will also be touching briefly about fungal sinusitis in cases where the patient is immunosuppressed, or patient is diabetic, or has been taking chronic steroids for some other condition. There can be a fungal rhinosinusitis. If the patient develops complications such as a periorbital edema, double vision, ophthalmoplegia, there is severe headache, there are signs of meningitis, then the chances are that the patient is starting to develop some complication, and then these patients need immediate referral to specialist. So what can be the complications? There can be acute complications because these sinuses are in close proximity to these vital structures. That is, they are close to the orbit, they are close to the intracranial structures. So the orbital complications may be seen in 60 to 75%. Amongst the complications, the orbital complications constitute 60 to 75%, and they are more commonly seen in children. There can be intracranial complications, dental complications, and bony confines of the sinuses may be eroded. Chronic rhinosinusitis, there can be complications such as development of mucocele, otitis media, and recurrent adenotonsillitis. So orbital and intracranial complications are more commonly seen in acute rhinosinusitis. So over here you can see that these are the collection of the purulent contents. So this is how you would classify the orbital complications. The patient can present with proptosis, chemosis of the conjunctiva, progressive ophthalmoplegia, and even complete loss of vision. So at the first indication of development of the complication, the patient should be referred for specialist management. So these are the red flags: periorbital edema or erythema, proptosis, any visual changes, headache, altered mental status, seizures, nuchal rigidity. These are all signs of meningismus or meningitis. So the patient needs to be referred. And also, if the patient is refractory to any treatment, and if you suspect fungal sinusitis, then these patients would need a referral to the ENT colleague. Fungal sinusitis we'll be touching very briefly. There can be a allergic fungal rhinosinusitis. This is seen in more than 70% of the patients. Or there can be an invasive type of fungal sinusitis. This is mostly seen in immunocompromised patients. Diagnosis is by imaging and biopsy and KOH smear of the secretions and tissue. And management requires specialist care, which includes surgery and administration of antifungals. So to summarize, I would like to say that we have to use judiciously the antibiotics, because all sinusitis is not bacterial, and initial stages we have to observe, give symptomatic care, and antibiotics should be given only if we suspect a bacterial rhinosinusitis. And the patient should be referred if there is failure to improve, or you see that there is a risk of development of complications. So immediately the patient should be referred. Thank you. I think any questions we will be taking in the end, or if there are any questions, I'll be happy to answer.
Yes,
Yes,
thank you,
ma'am.
Dr. Nilima. You will be staying with us for the.
Yeah.
Okay, then we can take it at the end. And Dr. Pasi has also been. Meanwhile, participants, please, you can write in the chat box if you have any questions.
Thank you so much, ma'am, for your insightful session. I would request all the participants to please post their questions in the chat box. We'll be addressing them all at the end of this session. Moving forward, I would like to invite our second guest speaker, Dr. J.C. Pasi, sir. He's a Dean cum Principal and Professor in the ENT Department of World College of Medical Sciences and Research, Haryana. And he was recalled by Delhi government for the second time as MD LNJP Hospital as a special case to convert Lok Nayak Hospital, GB Pant Hospital, and Guru Nanak Eye Center into first biggest COVID management facility. And he is an advisor to UPSC and various universities and public service commissions. He has innumerable publications in Indian and international journals, and he has also served Delhi AOI as President, Honorary Secretary, Treasurer, and Executive Member. He's also the President of Neuroequilibriometric Society, NES, and the All India Rhinology Society, AIRS. Today, he would be taking up the session of Management of Epistaxis in Primary Health Center. Over to you, sir.
Full screen, yeah. Okay. Am I audible?
Yes, sir.
Unmute.
Yes, sir. Yes, sir.
Okay. So, first of all, I will extend my gratitude to the organizers for inviting me for this very useful discussion on a very common topic, which our medical graduates as well as the paramedical staff posted in primary health centers, community health centers, smaller cities should know how to manage a case of epistaxis. So for choosing this subject also, I want to convey the gratitude, and epistaxis I'm going to discuss. So this epistaxis means bleeding from inside the nose. Any bleeding from the body's surface from anywhere in the body is a frightening symptom. It brings fright to everyone, including doctors. Anybody who sees fresh blood will be a bit scared. So anxiety is something which is going to be there. But before that, we will like to tell our non-medical audience that nose from outside it looks one, but from inside it is divided into two equal halves called nasal cavities. Laser point. Cursor chalaunga. Okay. This is the nose. Can you see the cursor? Can the cursor be seen?
Yes, sir. Yes, sir.
Okay. So this is the tip of the nose. This central thing forms the septum, which divides the nose into two nasal cavities. So it has two nasal cavities and one midline structure that is called septum. And bleeding can arise from any of these structures from inside the nose. This is called epistaxis. Bleeding, if it occurs from outside the nose, from the external nose, it will not be called as epistaxis. So as this picture says, that bleeding from inside the nose is called epistaxis. It is fairly common and is seen in all age groups, and patient often presents as an emergency. Epistaxis is a sign, it is not a disease. It should not be taken as a disease, it is a sign of some disease. And an attempt should always be made to find out the local or the constitutional cause or the general cause or a systemic cause. So what I want to say is that epistaxis should be treated as a symptom. Of course, this symptom has to be treated and then the patient has to be investigated for the cause. Our medical graduates would like to understand a bit about blood supply of the nose, which is required in this particular topic because this is epistaxis, and one who is going to treat patients should be having a bit knowledge of our vascular system of the inside of the nose. So important thing is that blood supply of the nose is provided both by external carotid as well as by internal carotid arteries, both on the nasal septum as well as the lateral canals. So on the nasal septum, if we talk, then we will understand that in the internal carotid septum, the branches of the ophthalmic artery called anterior ethmoidal and posterior ethmoidal are supplying. And out of the external carotid system, sphenopalatine artery, branch of the maxillary artery, again septal branch of the greater palatine branch of the maxillary artery, and a branch of the facial artery, which is called superior labial artery. These contribute in the formation of the entire vascular structure of the inside the nose. For example, this one is the branch of the facial artery here. This one is the branch of the maxillary artery, these two, and these two are anterior and posterior ethmoidal arteries, which are branches of the internal carotid system. And the confluence of these four vessels here in the inferior part of the nasal septum is called Little's area, which we will discuss just now. The blood supply of the lateral wall of the nose is again by the same internal carotid system as well as the external carotid system. The same branches supply on the nasal septum as well as on the lateral wall of the nasal cavity, from where the blood is likely to come. This is an important area called Little's area. Little's area is situated in the anterior-inferior part here, anterior-inferior part of the nasal septum. This area is called Little's area. It is situated in the anterior-inferior part of the nasal septum, just above the vestibule. What is vestibule? Vestibule is this structure, this one. The skin of the nose goes inside and stays there for some time, and then it becomes a mucocutaneous junction and then the entire mucosa. So the skin part of the inside of the nasal cavity is called vestibule of the nose, and just posterior superior to that lies this confluence and osmosis of 4 vessels, which is called Little's area, and this plexus is called Kesselbach's plexus. And it is formed by anterior ethmoidal, superior branch of the superior labial, septal branch of the sphenopalatine, and septal branch of the greater palatine arteries. As I said, little area is exposed to the drying effect of inspiratory current and to fingernail trauma, and is the usual site for epistaxis in children and young adults. As you can see in this picture, he is constantly nailing, and the trauma on the soft mucosa of the nasal cavity, especially over the little's area where there are vessels coming together and are superficially placed, can expose the mucosa and cause injury and lead on to bleeding. In fact, school children will report in primary health centers more often for symptoms of epistaxis than others. This is because of drying up of secretions inside their nasal cavities, and this itching, which stimulates this nailing process, causes that bleeding, and this bleeding generally comes from that Little's area we have just talked. Similarly, the retrocolumnar vein, this vein runs vertically downwards just behind the columella. It crosses the floor of the nose and joins venous plexus on the lateral nasal wall, and is a common site for venous bleeding in young adults. So whenever we perform surgery on the nasal septum in adults, this retrocolumnar vein generally comes into picture and is one of the causes of bleeding during surgery. What are the causes of epistaxis? We have to know as medico as well as non-medico what are the common causes of the epistaxis, why it happens. So these causes may be divided into local causes or general causes. And there are some causes which there are some certain conditions which we don't know is grouped under idiopathic group. In the nasopharynx, we have the adenoids. Infected adenoids can give rise to some bleeding spots sometime. Juvenile angiofibroma is one very important, not very uncommon condition in adolescent males. It doesn't happen in females. It happens in very young males and is the cause of very massive nasal bleeding, those who have juvenile angiofibroma. It is a bloody tumor which happens quite often and is a cause of worry sometimes, because if the patient is not attended on time, the patient can bleed and can lead on to serious complications. Similarly, malignant tumors in nasopharynx can also be the cause of blood-stained nasal discharge. Local causes can be, you can see, this can be a local trauma as we have discussed. This is facial trauma due to external injury, but this local trauma is caused by frequent fingering of the nasal cavity. Similarly, we can have stuck foreign bodies as the cause of bleeding from the nose, and neoplasm, as I said, nasopharyngeal angiofibroma can stay in nasopharynx and it expands into the nasal cavities and various adjoining sinuses. Similarly, there can be some anatomical irregularities like deviated nasal septum with a sharp spur can cause bleeding sometimes. Acute sinusitis, acute rhinitis, very severe acute rhinitis can lead on to some bleeding sometimes. And these are the conditions which happen because of the overuse of nasal sprays, whether these are steroids or decongestants. These can cause prolonged use of these sprays can cause epistaxis. And then there are neoplastic conditions in the nasal cavity which can lead on to epistaxis. Out of the general causes, we should know that there are systemic diseases which can be the cause of epistaxis. It is not always local cause. Cardiovascular system, hypertension is so common. It is very common cause of epistaxis in adults and in elderly people. Hypertension is very well known to cause epistaxis. Similarly, arteriosclerosis, mitral stenosis, pregnancy. Because of the hormonal changes, we see ladies bleeding, coming with bleeding with no obvious reason. And this happens due to the hormonal changes inside the body and happens in the last trimester of the pregnancy. And preeclampsia cases also, because of the high blood pressure again and the hormonal changes put together, give rise to frequent episodes of mild nasal bleeding. Similarly, disorders of the blood and blood vessels like aplastic anemia, leukemia, thrombocytopenic purpura, hemophilia, vitamin K deficiency, etc., can also be the reason for bleeding from the nose. Liver cirrhosis is very important and very common condition amongst alcoholics. Hepatic cirrhosis is one of the reasons because it brings lack of coagulation factors leading on to bleeding from various parts of the body, including nose. Similarly, renal failure, chronic renal failure cases can also come with epistaxis at times. Then we should know that there are certain drugs. Dr. Sangeeta will definitely talk about these drugs. Excessive use of salicylates, analgesics, which we do very common and very casually, and anticoagulant therapy. Those who are cardiac patients, they keep on taking anticoagulants for a long time, and excessive use can lead on to bleeding from the nose as well. Similarly, tumors of the mediastinum, acute general infection, and during menstruation also sometimes the young ladies come with the history of epistaxis at times. So what are the various sites of the epistaxis inside the nasal cavity? Commonest is Little's area that we have discussed, Kesselbach's plexus. In 90% of the cases of epistaxis, bleeding occurs from this site. So this is the site which one should try to see first of all. You only have to do an anterior rhinoscopy. You have to put your speculum inside the anterior end of the nasal cavity and just lift it and try to see toward the septum, and you can see a bleeding point from a raw area on the Little's area side of the septum. And this bleeding can be above this is the middle turbinate. This can be above the middle turbinate level, which happens in elderly hypertensive patients, and it can be below the middle turbinate. It can come from the posterior part of the nasal cavity, and it can be a diffuse septal or lateral nasal wall bleeding, that like it happens in coagulation disorders and other systemic causes. Then there can be bleeding from the nasopharynx, which will manifest both inside the mouth. It will drip down the pharynx and come out through the mouth, and it can also come into the nasal cavity anteriorly and come out as epistaxis. Classification of epistaxis clinically is into two parts. We call it anterior epistaxis and posterior epistaxis. When the blood flows out from the front of the nose with the patient in sitting position, when the blood is coming anteriorly out of the external nose, nares, we call it anterior epistaxis. And when mainly the blood flows back into the throat, patient is sitting and bleeding is coming from the throat, and the patient may swallow it and later have a coffee colored vomitus, because many times the posterior epistaxis is missed because mostly it goes into the nasopharynx and trickles down the oropharynx and into the digestive tract and accumulates in the blood and in the stomach and comes out as coffee colored vomitus. But posterior epistaxis can come both. It can go inferiorly into the throat and it can come anteriorly into the nasal external nose also. So if we differentiate between anterior and posterior epistaxis, we'll know that the anterior epistaxis is more common and it mostly comes from the little's area or the anterior part of the lateral wall, whereas posterior epistaxis come from the posterior superior part of the nasal cavity, often difficult to localize the bleeding point and occurs mostly in the elderly age group, whereas the anterior epistaxis happens mostly in children and young adults. The anterior epistaxis generally is caused by trauma, whereas posterior epistaxis is generally spontaneous. Similarly, bleeding is usually mild in anterior epistaxis. It can be very severe in posterior epistaxis. So management, that is our main topic. At primary setup, how should we deal with a case of epistaxis? That is what we have to understand today. In any case of epistaxis, it is important to know the 8 written points here. One is, how has it started? Is it spontaneous or is it after fingernail trauma or any external trauma? 1. Number 2, duration and frequency of bleeding. How much time long it lasts whenever it happens and how many times it happens. Is it every day, once a week, once a month? Right. Amount of blood loss. This is again very important. As I said, that epistaxis is a frightening symptom. It will lead on to a lot of anxiety and sudden increase in blood pressure, and that further leads on to increased amount of blood loss. Amount of blood loss, how do we calculate? How much blood loss one can afford? We calculate the amount of blood in any individual on the formula of 70 ml per kilogram body weight. So if you are 70 kg of weight, you should have 5 liters of blood in your body. And our science says that 10% of the total body volume of the blood can be lost without any need for substitution. That means if about half a liter of blood or less is lost, then you don't have to immediately rush for blood transfusion, etc., etc. You should go for the conservative medical management unless the blood loss is so severe, so rapid, happening rapidly for a long time, and patient has bled for more than half a liter, then of course we have to start thinking about the substitutes, blood substitutes and blood transfusion, etc. Then the side of the nose from where the bleeding is occurring, this is important. Whether bleeding is of inferior or anterior or posterior type. It is anterior bleeding or posterior bleeding. This is very important because you will then come to know about the causative factors. Any known bleeding tendency in the patient or in the family is to be noted. Any history of known medical ailment like any cardiac issues, like any leukemia, etc., etc. This history should be complete. And history of drug intake, as I said, certain excessive use of drugs can also lead on to the recurrent episodes of epistaxis. So history of drug intake should also be taken. So these are the points which everyone should remember and should note down as and when the patient comes. Of course, while the patient is bleeding, you may not be able to take all these long history points. The attendants are there to tell you all this. You can be busy with the patient and your colleague can ask about the history part while you will be busy in managing the patient. So what is the first aid that anybody, whether they are graduate medicos or non-medicos, paramedical staff, nurse, anybody in the primary health center can try to do it. So little area, if the bleeding is coming, anterior bleeding from the little's area, pinching the nose with thumb and index finger for about 5 minutes leads on to compression of vessels. And also the bleeding and clotting time of the patient is also over after 5 minutes to 7 minutes time. So this is the simplest way of controlling the bleeding, which is coming from, say, Little's area for whatever reason. Without patient has to be reassured. You have to reassure the patient that patient ठीक हो जाएगा. Patient is worried and patient is anxious, and sometimes you have to give some anxiolytic medical treatment also. You can, if the patient is bleeding very profusely, then you have to establish the IV line also, start with the fluids to combat the hypovolemia. At the same time, you should think of managing blood substitutes and the blood transfusion if required. Trotter's method of controlling the bleeding, the patient is made to sit, leaning a little forward over a basin to spit any blood, like this position, and breathe quietly from mouth. This is important. And at the same time, cold compresses should be applied to the nose to have a reflex vasoconstriction. Reflex vasoconstriction, because of the cold temperature, will very rapidly stop the bleeding. So this is one Ramband which everyone should know and should try as first line of treatment after reassuring the patient. And most of the time, if the bleeding is anterior, it will stop. Then cauterization. At primary health center, I don't expect cauteries and endoscopes availability, but silver nitrate is one, freshly prepared silver nitrate is one chemical which can be available at primary setup also. And once you can see the bleeding point after raising the tip of the nose or putting the nasal speculum inside, and if you can locate the area, then you can first give local anesthesia, followed by a bead of silver nitrate can be put over it as a cauterizing agent, and bleeding stops very rapidly. Surprisingly, it gives a very instant good result. And of course, coagulation with cautery, if you have the system available, this is certainly better than any other method. Now, this is something which is expected from all the medical graduates. During internship itself, we try to teach them how to do anterior nasal packing. This is another short method of controlling anterior bleed. We do anterior nasal packing if the bleeding is profuse and the site of bleeding is difficult to localize. Anterior packing should be done. A ribbon gauze soaked with liquid paraffin or any lubricating agent is used. About 1 mm meter gauze is required for each nasal cavity in adults. Few centimeters of the gauze are folded upon itself and inserted along the floor, and then the whole nasal cavity is packed tightly by layering the gauze from floor of the nose towards the roof and from before backwards. Packing can also be done in vertical layers from back to forwards, but generally we do this method. This is a picture showing a vertical method, and this is the one which is showing the horizontal method. This is the one which we generally use. We start, this is the base of the nasal cavity. This is the lateral view of the nose, base of the nasal cavity, floor of the nasal cavity. Along the floor, we go like this, posteriorly as we can. We put the nasal speculum, of course, inside the nasal cavity. And then we come like this, and this, like this, like this, like this. And then finally we come out again like this. So this is anterior nasal packing, which is always a very unpleasant experience for anyone whose nasal cavity is packed like this. Because of the emergent situation, the patient is bleeding. Bleeding point is not visible. That is the indication of intranasal packing. We do not have the anesthetists available. we only make use of surface anesthetics. We spray or we put the nasal the drops before we start nasal packing. We reassure the patient. We ask the patient to keep the mouth open and take deep breaths while we are packing. In spite of all those assurances and delicate handling, the procedure is very uncomfortable, and unilateral nasal packing generally doesn't help, even if the bleeding is coming from one side. So it is always advisable to pack both the nasal cavities to have complete hemostasis. Posterior nasal packing is required for patients bleeding posteriorly into the throat. This is again the lateral wall of the nasal cavity, showing how we pack the posterior nasal cavity, including the nasopharynx. This is one catheter which has been passed into the nasal cavity and has been brought out through the mouth. This is the tongue, this is the palate, this is the floor of the nose. The palate forms roof of the mouth, oral cavity, and the floor of the nasal cavity, which is the same structure which separates nose from the mouth. So this catheter goes like this into the nasopharynx and comes into the oral cavity and comes out, where this thread is tied, and this is the pack which is going to be pulled, like we pull out this catheter. Along with this whole thing comes inside the nasal cavity through this route, and it gets stuck here, and then rest of the thread can be brought out, and then it can be fixed outside in the nares with the help of another gauze outside, so that there is no cut on the skin with these sutures, which this thread which is going to stay for 72 hours on average. So this is one method of packing the nasopharynx for the posterior bleeding. But another method is that we have a special catheter available these days, which go into the nasal cavity, inflate it, and there is a central catheter which will keep the nasal airway patent, so that you can breathe also, as well as at the same time there are balloons which have been inflated, and these are keeping the bleeding areas under control. But then this method we did not find to be very effective, because it does not go into all the spaces inside the irregular nasal cavity structures. This is the picture of the endoscopic pictures of bleeding patients. This is the anterior ethmoidal artery, which is cauterized under endoscopic view. Similar, this area has been cauterized. These are the other latest methods of controlling bleeding, which are very, very effective. And nasal endoscopes have come into picture to control bleeding even for the posteriorly bleeding patients, which is generally due to anterior posterior ethmoidal vessels, and these can may not be found, but the bleeding point can be cauterized under nasal endoscopic view. So this is endoscopic cauterization. I've just told you. Elevation of the mucoperichondrium is something meant for ENT surgeons only. I am not going to discuss it here. Yes, ligation of the external carotid artery outside in the neck is done, and similarly embolization of the external carotid system is required when the bleeding does not stop in spite of all the conservative methods that we have discussed. These are the last resort procedures that we have to adopt sometimes. Like in angiofibroma, when we were students, we used to ligate this external carotid artery an evening before the surgery, so that the bleeding vessel goes down and intraoperative bleeding is minimum. But now we have very good methods of controlling intraoperative bleeding, and this embolization is one of the procedures that is done. These are the modern procedures. We don't need to discuss at primary health center levels. Ligation of the vessels, that this is what I discussed right now here. Other techniques are the endoscopic ligation of the vessels, embolization, we have discussed. And this was the last slide. Thank you very much for the patient listening. And I think me and Dr. Nilima will be ready for question answers before Dr. Sangeeta or after Dr. Sangeeta finishes.
As you wish, sir. Thank you.
Thank you so much, sir, for this insightful session. I would request all the participants to please put their questions in the chat box. We'll be addressing all those questions at the end of the session. Now, moving forward, we have with us today Dr. Sangeeta Sharma, ma'am. She's the president of DSPRUD, an NGO in the forefront of promoting rational use of medicines and improving accessibility, availability of quality drugs since 1996. She has conducted nearly 200 to build capacity for doctors, nurses, and pharmacists. And she has a rich and diversified professional and managerial experience in health.
Okay.
One of her pioneering work is book namely Standard Treatment Guidelines, a manual for medical therapeutics. Now I would request ma'am to please share her insights on balancing efficacy and safety, use of decongestants, antihistamines, and corticosteroids in sinusitis. Over to you, ma'am.
Thank you, Shreya. Can you see my screen?
Yes, ma'am, it's visible.
Okay, after listening to the detailed etiology, pathogenesis, clinical presentations of sinusitis and epistaxis, let me address, because many of these require multiple, pharmacological approaches for their management, whether sinusitis is acute or chronic. You may have to use several pharmacological agents for the management. So, but if you look at the effective management of sinusitis, there has to be a careful balance between symptomatic relief, targeting the underlying cause, and minimizing the adverse effect from pharmacological So this is the goal of the pharmacotherapy. So symptomatic relief is very important, because when this happens, the nasal blockade, sneezing, running, pain, all these things, and the infection control, inflammation reduction, and prevention of complication is the goal of treatment when we are managing the sinusitis. Now, the drugs which are used for symptomatic relief in these patients, namely decongestant, antihistaminics, corticosteroids, and antibiotics, these are majorly used, and their use is guided by the type, whether the presentation is acute or a chronic one, etiology, whether it is a viral illness or a bacterial illness or allergic cause is there, and severity of the symptoms. So whenever we are choosing these pharmacotherapy options, we need to keep these in mind, and the goals, what are we trying to achieve. The major principles behind pharmacotherapy are that we ensure appropriate indications for the management, use effective and safe medications which are safe for the patient, minimize duration and dose of these agents. I will be discussing about, what are the adverse effects, and, how much is the optimum duration, especially for decongestant, and prevent adverse effects and drug resistance. As you know, antibiotic overuse, misuse of antibiotic can promote or accelerate antimicrobial resistance, and which are very often used in sinusitis. So, okay, let's have, we have this scenario here. A 30-year-old man presents with nasal congestion due to common cold. He has been using the over-the-counter oxymetazoline nasal spray for 10 days and now complains that his congestion feels worse. How best can you explain this condition? You know, we know that the oxymetazoline is a decongestant, but after using it for some days, now the patient is saying that his congestion feels worse. What do you think is, is the cause of this worsening of his symptoms? You can write in the chat box. I can see that. Are you writing? Maybe today I can't see. Okay, fine. Okay. There is another scenario. A 60-year-old man with hypertension and benign prostatic hyperplasia complains of nasal congestion, and he asks about using oral pseudoephedrine. So what is the most appropriate advice for this patient? Would you recommend pseudoephedrine without concern here, or suggest pseudoephedrine only at night, or advise against use of pseudoephedrine due to possible cardiovascular effects, or prescribe long-term nasal steroids instead for this patient? Yes, I can. Are you writing in the chat box? Okay. Yes, I can see that. Yes, very right. The pseudoephedrine also used as a decongestant, but this should be used very carefully, particularly in patients who are suffering from hypertension or have cardiovascular diseases. So the most commonly decongestants that we use are oxymetazoline, usually by the nasal route, and pseudoephedrine by the oral use. The mechanism is that they cause vasoconstriction and thus they reduce the mucosal edema. So indications are short-term relief of nasal congestion. Caution should be prescribed whenever we are using these decongestants. It should not be used for more than 3 to 5 days because there is a risk of rebound congestion here, and the oral decongestants are contraindicated in hypertension and high heart disease. So use only these agents only for symptomatic relief in acute cases only. Long-term use should be avoided. This decongestant only use this for symptomatic relief for acute sinusitis with significant nasal congestion and eustachian tube dysfunction. And oral is effective but carries a risk, so be mindful of prescribing this oral decongestant. And as I said, it should not be prescribed for more than 3 to 5 days. And particularly oxymetazoline nasal sprays are not recommended for children under 6 due to risk of rebound. Congestion can happen in both adults and children, but here besides rebound congestion, there is a risk of systemic absorption of these. So oxymetazoline should not be prescribed in children under 6. Now, what is this rebound congestion due to? This is called rhinitis medicamentosa if you use it for more than 3 to 5 days. So here the patient may on continued use of these nasal decongestant, itchy nasal passages, runny nose, sneezing, and stuffy nose. So gradually these drops, if patient had been, over the counter use is very common. Many of us go and buy these drugs from the counter. But if they happen to develop this rebound congestion, it should be gradually reduced, and stopping abruptly can worsen symptoms. So one can rely on the alternatives. Saline nasal irrigation is another safe or cheap, safe, effective alternative here. Or if the symptoms are persisting, a patient is allergic, we can think of intranasal corticosteroid for reducing inflammation, and steam inhalation can also provide some symptomatic relief in this patient. So alternatively, for children, especially, nasal drops are used for treatment of nasal congestion in infants and young children. Again, indications are if the congestion is due to cold, allergy, or sinusitis, or you can also use them for dry nasal passages. This which can happen from dry air or prolonged indoor heating in winter time, and post-operative nasal care, or it can be used as an adjunct to intranasal corticosteroids to clear mucus and improve absorption. The benefit of nasal drops in sinusitis is that it can hydrate the nasal lining and reduce irritation, loosen thick mucus, aiding in drainage of the discharge from the sinuses, and it can flush out allergens, bacteria, and debris, and enhances the effectiveness of other nasal medication. Now, let's see, there is another situation. A young woman has had a chronic dry cough for 4 weeks, worse at night, with a history of allergic rhinitis. Chest X-ray is normal. Now, which of the following is the most appropriate antihistaminic approach? Now, besides decongestant, antihistaminics are used for these conditions. So first is you can use diphenhydramine twice daily, Montelukast plus loratadine, hydroxyzine at bedtime, or there is no role of antihistaminics in allergic cough. Let's see what are the okay. Okay, let's see. Okay, so we can use both antihistaminics and Montelukast here. Montelukast is a leukotriene receptor blocker here, which is again reduces the inflammation. These are particularly used for allergic rhinosinusitis. There are two generations of antihistaminic. First generation, diphenhydramine, but they are sedating and may impair mucociliary clearance. So these should be especially used with caution in elderly because they are sedating, and since they can impair mucociliary clearance, again the utility one has to look at, because they may be counterproductive by drying these secretions. Then there are second generation agents like loratadine, cetirizine. These are safer and better tolerated. They have they are promoted as non-sedating antihistaminic agents, but some patients may still have sedation with the second generation antihistaminics as well. Now, because, let's see, this is an 80-year-old man with a benign prostatic hyperplasia and mild dementia, is taking diphenhydramine for itching. He presents with confusion and urinary retention. What do you think? What is the cause of likely cause of his symptoms? Is it progression of dementia, urosepsis, or adverse effect of diphenhydramine, or dehydration? Yes. Okay, very good. See, this is adverse effect of diphenhydramine. Already this patient, this is an elderly patient having dementia, and use of this diphenhydramine, because these patients, elderly people, may also have skin drying and itching may be there, or maybe it could be the side effect rashes due to the one of the medication they are taking. So they may be taking this over the counter or as prescription drug, but that is why these antihistaminics are to be used very cautiously in elderly patients because they can cause confusion and urinary retention. So generally second generation are well tolerated. Patient may have occasional headaches or dry mouth. Alternatively is that we can use leukotriene receptor antagonist like Montelukast. Allergen avoidance is the best treatment actually for allergy treatment, but many a times we are not able to identify the allergen here. So you may have to resort, but then you have to see the nasal corticosteroids are a better choice for allergic inflammation in these patients. Now, coming to Montelukast, this has also become this is also used as asthma for both prophylaxis and chronic treatment, but usually it has been seen given as an add-on therapy to inhaled corticosteroids, but if given alone it is usually less effective than inhaled corticosteroids. So anyway, inhaled corticosteroid are the best choice for treatment of asthma, but if the symptoms are not controlled, for symptomatic relief, particularly if it is exercise induced bronchospasm, or if there is a seasonal or a perennial allergic rhinitis, Montelukast is a good choice. The areas with the Montelukast are headache, abdominal pain, diarrhea, cough, and dizziness. Some of the ADRs are serious, but they are seen rarely, but you should be aware of it, that it can cause mood changes, agitation, or depression. So be mindful of it. So that is why it is said Montelukast should not be used in patients suffering from mental disorders like depression or schizophrenia. It can also still have allergic reaction. Stevens-Johnson syndrome is the life-threatening serious reaction with Montelukast. Therefore, Montelukast should be used with caution in patients with mental health disorders, liver disease, or phenylketonuria. And so also keep this in mind, this is not a substitute for rescue inhalers in acute asthma attacks. This is used as an add-on for symptomatic relief, but not as a rescue replacement for rescue medicine while the patient is having acute asthma attack. And if the patient is on Montelukast, monitor for behavioral changes, especially in children when you are using Montelukast. Then corticosteroids are another mainstay of treatment. Intranasal corticosteroids are preferred, like fluticasone, mometasone. They are indicated in chronic sinusitis with or without nasal polyps, acute sinusitis with significant inflammation. There are studies now which are supporting this. Then allergic rhinitis. In fact, in allergic rhinitis, this intranasal steroid should be introduced early for these allergic cases proactively. It's not, if the patient is having recurrent symptoms, chronic symptoms, allergic symptoms, these intranasal steroids are very helpful. And they are helpful, safe for long-term use, and they improve mucosal health. As Dr. Nilima was saying, systemic corticosteroids are reserved for severe or refractory cases due to potential systemic side effects. So by and large, most of the time, intranasal or inhaled corticosteroids are useful for the patient. Systemics are reserved only for acute or severe refractory cases only. So systemic, as you know, has its own side effects on long-term use. It can suppress the HPA axis, but 1 week of systemic corticosteroid does not require tapering of these steroids, but should be, they are contraindicated in patients with active untreated infections, especially TB or fungal infections, and these should be used with caution in patients with diabetes, osteoporosis, or peptic ulcer disease. Now, again, these intranasal steroids can cause nasal irritation, epistaxis. This could be, rarely septal perforation, but systemic corticosteroids have more of these side effects. They can cause weight gain, mood changes, hyperglycemia, adrenal suppression, as I told you. Alternatives are that we can use saline irrigation or antihistaminics for allergic component only. This will not help in the asthmatic or surgery in refractory chronic cases. Antibiotic is another area which are very frequently overused, misused in sinusitis. Dr. Nilima very clearly, presented that most of these sinusitis is viral in nature. You will see superadded bacterial sinusitis in a very small number of patients, from 0.5 to 2%. So, but basically, most of us believe that the sinusitis is bacterial and we start with the antibiotic. But if you look at the etiology, it is viral in nature. So antibiotics should be reserved only for suspected or confirmed bacterial sinusitis. You can suspect this if the symptoms have been there for more than 10 days, patient has severe symptoms. Mild fever is not an indication. You can still have with this viral sinusitis. If the fever is above 39 and facial pain is there and the fever has been there for 3 to 4 days, then you can suspect that perhaps the patient is having bacterial sinusitis. Or sometimes, it may start as a viral sinusitis, but later the bacterial sets in. So you may see this worsening after initial improvement. It is called double sickening. If these are there, then only antibiotic should be used. Amoxicillin clavulanic acid is the first choice. But one thing very important with antibiotic use is we must document and justify antibiotic use. If we get into this habit of writing, documenting the antibiotic, why are we using this antibiotic for a case of a sinusitis? Perhaps this will reduce the misuse of antibiotics for treatment of viral sinusitis. So note the criteria met. There are criteria, indications for bacterial sinusitis. So maybe you can write persistent symptoms for more than 10 days with purulent discharge and facial pain. So perhaps this will justify. This will support the stewardship activity and protect you medical legally as well. Many of you, when we ask you to withhold antibiotics for the management, they say, how do we, defend ourselves if somebody later on questions why did you not use antibiotic for the treatment? So here, if you document the criteria met, why are you using or why are you not using, this will be helpful for your defense. Now, as the duration, sometimes discharge for 3 days, she asked for antibiotics to speed up recovery. So, many a times patient will come and demand for it. So here you need to prepare your patient you have to answer their expectations. Most of the time patients expect that antibiotic will be prescribed for sinusitis. So one has to see, it is less than 3 days or the symptoms are not so severe, fever is going down. Perhaps these are the symptoms where when you can say that the antibiotics are not needed. And also, antibiotics, besides this problem of antimicrobial resistance, many of us believe that antibiotics are harmless. And just to meet the patient's demand, we prescribe. But these antibiotics do have side effects, GI upset, nausea, diarrhea, hypersensitivity, rash. These are, and with repeated use of antibiotics, there could be a problem, C. difficile infection, especially if we use broad spectrum agents. Many a times these chronic sinusitis patient, they keep getting the repeated antibiotics. So this is the time when you use this C. difficile infection. This is very hard to treat if the patient suffers from this infection. This is very, almost, you need a very higher end antibiotic to treat this, and admission is required. So one should avoid these. So what are the alternatives that we have is that, in the outpatient care areas where the patient is, maybe we can advise watchful waiting in mild cases, moderate cases, and you can clearly explain to the patient if symptoms do not improve or disappear. It would improve. It usually takes week or 10 days for sinusitis. So if symptoms do not improve within 3 to 5 days, then maybe you will go for an antibiotic. So I think this strategy works very well for, and spares antibiotic for the treatment of sinusitis cases. Or you can say delayed prescription strategy. Doxycycline or macrolides can be prescribed in penicillin allergic patients. Personally, I feel fluoroquinolones should not be prescribed for regularly prescribed, because these are reserved for as a second line drugs for MDR TB. So if we use these fluoroquinolones in undiagnosed cases, perhaps this can accelerate resistance and make the treatment of TB difficult. So I think with this presentation from all the experts, and how would you like to treat 30-year-old with 6 days of nasal congestion, mild headache, no fever? What would be your treatment plan for this patient? Why am I doing this? Although this may sound as a repetition, but I think these are the kind of scenarios that we keep seeing every day. And although there is a knowledge that antibiotics should not be used, or this is the criteria for prescribing antibiotic, but somehow when it comes down to prescription, we see a similar pattern. Okay, very good. You're saying that only symptomatic treatment would be required, maybe with the saline irrigation, short course nasal decongestant, and no antibiotics. So because the rationale behind is that it is likely viral, and supportive care will take care of these patients. So I think if take home messages is that you treat sinusitis based on the cause and severity, differentiate between viral and bacterial sinusitis. That's the major critical area. If we are able to understand and we the difference between viral and bacterial sinusitis, perhaps antibiotic prescriptions will go down. Avoid polypharmacy as far as concerned. Look for prioritized non-antibiotic options in early stages. Educate patients on expected course of viral sinusitis to reduce unnecessary antibiotic use and adverse effect. Watchful waiting works very well for mild to moderate cases, and monitor comorbidities, of course, in patients with hypertension, diabetes, when you are prescribing any of these systemic agents. So I think we've all said this. There are red flag symptoms that you need to recognize and immediately refer these patients to ENT specialist. Don't withhold these patients at your level, at a primary level, to take care of it. I think I'll stop here. This is just the summary of the drugs used. Decongestant, use only when there is acute congestion, there is a rebound congestion or systemic side effect could be there. Antihistaminics should be reserved for allergy-driven symptoms. Avoid sedating types in non-allergic cases and in elderly patients. Corticosteroids you can use for both chronic or severe inflammation, but intranasal or inhaled route is preferred over the oral route most of the time. And I think more than almost always this inhaled route works well. I have heard people saying that the MDI inhalers are not working. Whenever these are not working or they are not able to relieve the symptoms, especially the bronchodilator inhalers, ethylene, salbutamol, it is mostly due to the empty canister. Although these days there is a meter there, then you know the number of doses remaining in the canister. If you are not using canisters with the meter, then perhaps because some propellant is there in the inhaler at the bottom always, so patient thinks that there is a medicine. So usually it is the empty canister or incorrect technique to take these inhalers. Otherwise, most of the time, these are very effective, and it is very safe also, because you are administering a very small dose directly going into the airways where it is needed. So many times patients do not like to use these inhalers or spray, thinking that, especially the inhalers, they because of the stigma attached to it. But I think with careful explanation to the patient that these are safe, you're using a 1,000 times less dose here, and it is very effective. Especially the bronchodilators, when used as a rescue inhalers, can provide immediate relief. So, with this, patient can be counseled for a better use of these inhaled corticosteroids. And of course, antibiotic, as I said, use only when it is probable bacterial infection. Avoid misuse and long duration of antibiotics. In one of the places I went, sometime antibiotic was prescribed for some upper respiratory tract infection, and this doctor tells me that this patient has been on amoxicillin for 1 year. Nobody stopped this. We have this habit of continue same medication, and it went on and on, and for over 1 year patient was taking this amoxicillin. So all kinds of usage, misuse happens. So please caution, I like to caution against the use of antibiotics. Use it. Definitely, if there is a need, you must promptly use it. But you have a criteria for this. Having mild symptoms, Dr. Nilima presented the criteria, 2 major, 1 minor, or like that. So use that criteria to make your decisions more informed and less likely that it is just by chance that we are trying to have a defensive prescription here for these patients. Thank you. I'll stop here. Now I think we can take all the three. Dr. Nilima, Dr. Pasi, both are here patiently waiting to take the questions.
Thank you so much, ma'am. I would request all the participants to please post their questions in the chat box now. Ma'am, we had one question wherein a participant asked that a 45 years male with DNS with chronic sinusitis with case of post-nasal drip operated with septoplasty and FES on nasal steroid antihistamine steam inhalation, but still case of post-nasal drip operated 1 year back.
I think Dr. Neelima or Dr. Pasi, you can take the question.
Can you
Yes,
repeat the
yes,
question?
sir,
What is the
please.
question? What is the question?
Yes.
Dr. Shreya?
Sir, yes, sir. The participant wrote that there's a 45-year male with DNS with chronic sinusitis with a case of post-nasal drip operated with septoplasty and FES on nasal steroid antihistamine steam inhalation, but still the case of post-nasal drip is there, and this was operated 1 year back.
See, this continuation of the post-nasal drip is not a very serious sign. I suggest that patient should continue with the post-operative medical treatment, and instead of using even nasal steroids and decongestant, he or she should come to nasal saline sprays and the steam inhalations for some, say, 2 to 3 weeks more, and then he should, whosoever the patient is, should get back to his treating surgeon. And sometimes there can be a possibility of incomplete eradication of the disease when we do functional endoscopic sinus surgery. But sometimes post-operatively it takes a lot of time. You cannot define whether patient will be having maximum benefit within 2 weeks after surgery or after 2 months. Sometimes it may take 3 to 4 months as well. So patient should have faith in the treating surgeon, should get back to him, and know, as Dr. Sangeeta has very clearly warned against a unnecessarily prolonged use of even local nasal steroids and decongestants.
Thank you so much.
Shreya, go on.
So there is one. Yes, ma'am, there is one more question. Is there any role of adrenaline 1:1000 ratio soaked nasal pack?
Yeah, that's a very good question. That's a very good question. Actually, we use adrenaline for a small time use of this drug as a vasoconstrictor. We do not treat epistaxis with adrenaline. For a very temporary relief, what we do is sometime in the nasal pack, which is paraffin based, or even nasal saline can be added with very mild 1 in say 2 lakhs of 1 in saline adrenaline can be used, but this is not recommended all times. The pressure of the pack will stop the bleeding, and adrenaline use should be minimum because of the rebound phenomena again here. So we do not recommend, I did not mention about adrenaline in my PPT at all, because we want to discourage the use of adrenaline, which is so very rampant. And many people will put the adrenaline in the form of drops in the nasal cavity in a bleeding patient. So all these things should not be done. It is not recommended.
Okay, sir. Thank you. Sangeeta ma'am, you wish to say something?
Yeah, there is a question about steam inhalation. How for sinusitis, is it good for sinusitis? If yes, what should be the frequency and for how much time steam inhalation should be done?
Steam inhalation is a least harmful way of getting some decongestion, some feeling of say less congestion in the nasal cavity and paranasal sinuses as well as throat. So we always recommend a simultaneous inhalation of steam through the nasal cavity as well as through the mouth, so that the oropharyngeal and hypopharyngeal walls are also covered in that. So it definitely gives you a feeling of smoothness. The raw feeling that you get in the nasal cavity and the oropharynx gets reduced, though it is not a specific antidote for anything. It is a supportive treatment which is harmless, and one can take it for a long time. Like Madam said, and amoxiclav was being used for 1 year. That's a crime. But using steam inhalation for 1 year is not a crime.
But be careful of when you are advising this steam inhalation for small children. So it should
Yes.
not be a direct.
We don't advise steam inhalation.
Yeah, maybe it can be used as a moisturization in the room, one corner. But again, you have to, if you have a toddler in the family, you have to be really very careful. You know, there have been cases reported, burns cases have been reported using this steam. But definitely, as Dr. Pasi is saying, steam inhalation provides symptomatic relief, and it has no side effect. I always say medicines are double-edged swords, but steam inhalation, if used properly. Is there any technique or something, would you like to say? And how many times in a day can they take?
It depends upon the climatic condition, madam. If you are sitting in Srinagar, even in summer, you can take twice or thrice even. But in Delhi, once at bedtime would be the ideal time. And if it is an acute congestion state, one can have it twice a day, even thrice a day. And inhalers are, those devices are available, but you can have a simple on your, open boiling water, giving steam is also good enough. Unless you are putting some medication in it, you don't have to even cover it. You just cover your head and take it straight.
Usually eucalyptus or something like this, Vicks, people like to, mix and, take the steam. Is that good?
What did you say, madam?
Eucalyptus, those Carval plus like tablets.
Carval is we recommend it only when we are asking to do steam inhalation in a patient who is having hoarseness. It has got a soothing effect on the laryngeal mucosa. So we confine this therapy only in that situation, on that condition. Hoarseness of voice, that's it. Nowhere else. Carval is not to be used for other purposes.
Dr. Nilima, there is a question for you. Is there any role of sodium chromoglycate? Please unmute yourself.
Sorry. Yeah, so it may be used in cases of allergic rhinitis, but to my mind, it does not have a proven role in cases of sinusitis as such.
It is mainly used as a preventer therapy for rhinitis because it acts by, acts on the mast cells and prevents the release of histamine and other mediators. But again, this has a prophylactic role, preventive role only, and mainly this is besides allergic rhinitis, it is used in allergic conjunctivitis, and it has a delayed onset of action, so continued use has to be there. But by and large, I don't think so. It is used as an add-on only, not as a mainstay of treatment.
Mainstay is intranasal corticosteroids.
Inhalation, role of inhalational agelastin, when should it be prescribed?
In some cases of allergic rhinitis, we do use inhalational agelastin sprays, but the mainstay is intranasal corticosteroids. We can use a combination of agelastin and steroid sprays.
Dr. Nilima, maybe I can ask you, did cover in the your presentation, what is the role of imaging in sinusitis? When should it be ordered? Is it, can you use this as a routine, anytime, any patient presenting with sinusitis? Because overuse of these investigation is also equally a concern here. So when do you
Yeah.
advocate?
So we tend to go for imaging if the patient is refractory to medical therapy, he has not responded to medical therapy, and also symptoms, if the symptoms are severe, nasal congestion, nasal fullness is severe, and it is associated with facial pain and pressure. It is chronic sinusitis and not acute sinusitis, then we need to go for CT scan. If we are planning for surgery, we will definitely need a CT scan of nose and paranasal sinuses to decide upon our surgical management.
So that
So
means you need it only, you do not need it for acute rhinosinusitis,
no,
but when the symptoms are persisting or the patient is, towards the chronic sinusitis, right? Then only you
Yes.
ask for it.
yes, yes.
Role of X-ray PNS in this.
The role of X-ray PNS is now decreased to a large extent because CT scans give you the whole idea of the whole anatomy. And for surgical management, X-ray is not effective at all. We need to go for a CT scan to see all the sinuses in the various cuts. We are able to see what is the exact pathology. The X-ray gives you only a two-dimensional picture.
So if at all when needed, you
Dr.
should ask.
Sangeeta, can I add something?
Yeah,
Yes, sir.
Dr.
About
Pasi.
X-ray. Though I did my thesis on X-ray paranasal sinuses, but I don't remember how many years back I prescribed one X-ray PNS. We don't prescribe X-ray PNS anymore because it doesn't provide you adequate information, as Dr. Nilima said. Instead, we go for one section of axial section of paranasal sinuses, non-contrast type, which is a very cost-effective way of getting CT scan. And we get a lot of information with that only. And it is not very costly also, and too much of exposure is also avoided. So we do tend to go towards CT, non-contrast paranasal sinuses CT quite often. Of course, I will always go for a contrast enhanced CT when I'm planning a surgical procedure on paranasal sinuses, or if I'm having some confusion in making the diagnosis, then also CT scan I will order, but not ordinarily for medical treatment.
Sir, this question is about epistaxis. There are two questions on this. But while packing, somebody asked, what should be the position of the patient? While packing, nasal packing, when you're doing nasal packing for epistaxis, what should be the position of the patient?
Patient has to lie down. It should never be tried in a sitting patient. Patient has to lie down on any table which with the head a bit raised. This is the position, surgical position in most of the nasal surgical procedures, that the head is slightly raised. And in nasal packing, sometimes we may have to have a straight head as compared to the body, and nasal packing should be done in that posture only. Sometimes some people try to do it in the and that couch, the patient's chair, but patient may not cooperate very well. Sometimes we have to hold the hands of the patient, and these things are possible only when the patient is lying down.
Okay.
It should be treated as a minor surgical procedure.
Okay. So tilting of the head backside is a common, bad practice. Actually, I remember as a child, I used to have a lot of epistaxis and massive epistaxis. And I don't know how it got better on its own.
It happens.
I used to have a episode of epistaxis. My mother or the relatives, they used to put my head under the tap, and they used to think that
still works. That still works.
It works
under the tap, maybe cold water. Now you can have better methods. पहले तो नलके के नीचे बिठा देते थे ना गाँव में.
This is they used to do that only. मेरे को उसके नीचे बिठा देते थे और पानी चला देते थे ऊपर से. So, but now I think
we are expecting vasoconstriction with that act.
Okay.
So cold compression can be done now. Application of cold on the nose.
Is tilting backwards good or bad, while you're providing this, trying to stop this bleeding?
What is the question?
In your presentation, you said the patient should be leaning forward.
Yes, that is,
Another common practice is that they ask the patient to turn head backwards.
we don't want the patient to have the bleeding going into the nasopharynx and then going into the stomach. We want it to come out so that we come to know about the severity and do not allow blood to go into the esophagus. And also this posture will help putting the ice packs or water or whatever to have the vasoconstrictive effect also.
Dr. Pasi, in adults, when they have epistaxis, it could be hypertension as the underlying cause for epistaxis. So how do you, manage both epistaxis and hypertension here?
See, as I said, the patient apprehension part has to be, alleviated as much as possible by giving reassurance, by giving some anxiolytic drugs, by starting the IV line while we are preparing for post-nasal pack. And of course, the anti-hypertensive medication, whatever patient is taking or is not aware, one has to start. And in extreme blood pressure levels, we have to sometimes give intravenous medication also. That has to go side by side while we are packing. Packing sometimes may not be required if we treat the hypertensive episode on immediate medication. But if we have to do it, then we have to do it. I have already told two methods of doing post-nasal packing, one with the pack, routine gauze piece, another one with the balloons with catheter.
This pack should be in position for how long?
Generally, we keep it for 48 to 72 hours.
Any precautions that need to be taken while removing the pack?
While removing the pack, one should be very slow in removing because it still is painful procedure while you are taking it out after 72 hours. And you make the nasal pack moist with normal saline. You keep on putting drops, remove a part of the gauze and put more normal saline drops. Some people add adrenaline, which is not required. Only normal saline will soften so that while you are taking it out, patient has minimum pain. Pain and bleeding again, of course, if the patient moves the head suddenly, it can again traumatize with the instrument being used inside the nose. So we should be very gentle. One should not be in a hurry to remove the pack. And after removing the pack, again, patient has to keep lying and we have to observe, keep the patient for a few hours so that we are sure that there is no more bleeding happening again.
How about use of antibiotics in patients who need this packing?
No antibiotics. If we have done it in aseptic conditions, no antibiotics are required, and that is why we don't keep it for more than 48 to 72 hours. If the pack is required to be kept for a longer period, then prophylactic antibiotics may be given.
But can we anticipate that this patient would need packing for a longer duration?
Yeah, in certain surgical procedures, madam, post-operative cases, sometimes we have to keep for a longer period, the anterior as well as post-nasal pack. In post-nasal packing, when we do, we also need to do anterior nasal packing. In most of the situation, we do both anterior nasal, posterior packing. This is one situation where pack may have to be removed. Anterior nasal pack we remove within 48 to 72 hours, whereas post-nasal pack, we are scared of bleeding again. And if we have not, suppose there is a coagulation disorder or patient has been put on triple anticoagulant agents for cardiac issues and the patient is going to bleed diffusely from the area which is already bleeding. So in those situations, we may have to keep the pack for a longer period and antibiotic is indicated, systemic antibiotic.
Otherwise, routinely it is not, if it is from nose, and it is not as, very bothersome bleed, but needs anterior packing.
No antibiotic.
No antibiotics are required. But this is again a common practice that, because we are doing some intervention, people prescribe antibiotics. Now, there is another question. Is epistaxis symptom of underlying malignant tumor in liver?
Yes, when a patient, elderly patient of 50 years plus, 60, 70 years plus comes with symptoms of blood-stained nasal discharge with nasal obstruction. Blood-stained nasal discharge with nasal obstruction and some puffiness of the face, of the nose, between the nose and eye, those kind of findings if we have, and with little bleeding through the nose, that is highly suspicious of malignancy.
Could it be because of coagulopathy?
That's always there. In that case, it will be a diffuse bleeding and from both sides of the nasal cavity and also maybe in the throat from the nasopharynx. Coagulopathy.
Because this is also, not very commonly recognized as a reason. If you have patient is having repeated epistaxis, so coagulopathy could be the under some, defect.
Factor deficiency.
Yeah.
These coagulopathies will be known to us even before the patient comes to us with epistaxis, because coagulopathy patients, children will be diagnosed much earlier with other symptoms. So it's not that epistaxis is the first manifesting symptom of coagulopathy, unless anticoagulants have been started in the recent past.
Sometimes, for some reason or the other, coagulopathy or the deficiency of these factors is not diagnosed. It may, present as epistaxis, but repeated recurrent epistaxis, perhaps one should think in terms of this cause also. There's a question about, yeah, please.
As I said, in liver cirrhosis, in chronic alcoholics, the deficiency of the coagulation factors occur, vitamin K deficiency occurs. So in those cases, there can be coagulopathy, which is not known, and one should have to keep this thing in mind while finding out the cause of epistaxis.
There is a question about what are the causes of posterior nasal bleeding in children. Is nasal packing done in children?
Very good question again. See, in children below 5 years, it is almost impossible to pack the nose. But there are not many conditions which will require nasal packing in children. As far as the bleeding in children is concerned, it is mostly due to nail trauma in the anterior cartilaginous part of the nose, which can be handled with conservative medical management. There are very few conditions like some tumor in the nasopharynx, some bloody tumor, or in the nasal cavity, papilloma and hemangiomas are known. Angiofibroma per se does not manifest very early in the say childhood. It manifests after 10 years of age and up to 20, 25 years of age, it can manifest. So these adolescents become adults when they come to us. So there are not many indications of posterior nasal packing in children, and if at all it is required, it will be under anesthesia. Otherwise, you can't expect children to cooperate for post-nasal packing.
Dr. Nilima, there are no more questions, but would you like to give some take-home messages for our audience here today? What to do and what not to do in case of when they see the cases of rhinosinusitis?
So a good evaluation of the patient, taking all points in the history and what all the symptoms that the patient is having, the duration of the symptoms, how long the patient is having those symptoms, to make the judgment whether it is just a common cold or an acute viral upper respiratory tract infection or it is a bacterial rhinosinusitis, so that the decision to how to manage the patient can be made. Then in children, if the patient is presented with acute sinusitis, then In children, the chances of it progressing on to complications is higher. So you have to be watchful that if there is an acute bacterial rhinosinusitis in a child, then it can lead to complications. So it needs to be managed and monitored. Then, as we both of us said, the judicious use of antibiotics. Not every sinusitis will need sinusitis. If it is a patient of chronic rhinosinusitis, then it's better to refer the person to ENT specialist so that he can be evaluated whether the patient is having polyps or patient is having a CRS without polyps. So if it is polyps, then it will require a kind of an aggressive medical management. And if the patient does not respond to the medical management, then the patient will be a candidate for surgical management so that the quality of life of the person improves. So in cases of chronic rhinosinusitis, I think it is better to refer the patient to ENT specialist so that the symptoms can be taken care of. Other than that, I think mostly I've covered in the presentation.
Ma'am, you're not audible. Sangeeta ma'am, you're not audible.
There is a question in the chat box. Causes of sinusitis in children, particularly who are doing swimming.
Causes of sinusitis, particularly in children who are doing swimming. So swimming sometimes leads to some upper respiratory tract infections, but mostly these are viral sinusitis, and it responds to symptomatic care and management. And so I don't think it often progresses on to bacterial.
Could it be chemical because chlorination is done in the swimming pools?
No, I don't think so. Water does enter the nasal cavities and it does affect the person, but I don't think it leads to sinusitis. The chlorine leads to sinusitis. But yeah, definitely, if it is a public pool, then definitely people who are having upper respiratory tract infection, they should avoid using the pool at that time.
Generally, what is the advice for public education besides therapy and diagnosis and all that?
See, common cold is very frequent in children. They suffer from this acute URTI, upper respiratory tract infection, common cold very frequently. So symptomatic management mostly settles these infections in 3 to 5 days. So always the use of decongestants, use of antibiotic is not required. And especially if you're using the public pools, then if you are having some infection, you should not use the pool at that time. But children have to play, so
yeah, you can't stop that.
you can't stop them.
They have to do some exercise. Anyway, I think the take home is upper respiratory tract infections are very common, but mostly are viral in nature and usually are self-limiting. They will be all right with or without symptomatic treatment. Very few cases will turn into have the superadded infection. One very misconception that we have is that we are using these antibiotics to prevent the superadded infection. Let me tell you, antibiotics do not work that way. If the patient has developed a secondary superadded infection, then only it will work. And you can always use these antibiotics whenever these patients develop. Using them prophylactically to avoid this superadded infection, it does not happen. So this actually then amounts to overuse of antibiotics. I think we had a very long session. Thank you to both of our resource persons here. Shreya, for sparing your time and sharing your expertise, experience with the audience. I hope they found it useful and they would be able to manage these cases well at the primary, secondary level of healthcare. I think red flag signs, if we know, patient should be immediately referred to a ENT specialist. With this, I think Shreya, would you
Yes,
like
ma'am.
to say anything, Dr. Pasi, Dr. Nilima?
Thank you very much.
Thank you, Dr. Sangeeta, for
Very
giving us.
excellent moderation, Dr. Sangeeta.
Thank you, sir. Thank you.
Thank you for giving me the opportunity. Thank you.
Yeah, thank you. You know, I should
Okay,
be
Dr.
saying
Sangeeta,
you
Dr.
spared time.
Nilima, and
Thank you, sir.
Shreya and
I
the
think we can close the session now.
Yeah.
You can complete the
Yes,
post-test and please do provide us the feedback on the sessions. This will help us in designing, improvising the format of the sessions. Plus, you can also indicate the topics of your choice that you would like us to cover in these webinar series. Dr. Pasi and Dr. Nilima, this is the third consecutive year of having this monthly webinar series, and we still continue to have the enthusiastic
Yes.
participation.
Keep it up. Keep it up. We are with you.
Very good initiative.
Yeah, thank you.
Thank you so
Okay,
much, everyone.
yeah, do give us the feedback. Please, the link is there in the chat box. Please give the feedback, fill up the post test. Only those who complete both pre and post test will get the certificate. You can watch the videos of a recording of this session on QPS YouTube channel. The link is already there in the even you can watch the previous sessions on this channel. This session's recording will be there in about 10 days time. So please bear with us because they need to do some background homework to prepare that YouTube video. So, but everything will be available on the YouTube. Thank you. And see you on 19th July. Next session, we will be discussing about diabetes, monitoring of diabetes patient, and especially diabetic foot care. We will be discussing. Okay, see you next month. Thank you.
Thank you.
Thank you so much,
Thank
ma'am.
you.
Thank you so much, everyone. Thank you.
Sanam.